The first line treatment of any case of severe hyperkalemia is injection calcium gluconate, and that we give by intravenous infusion. But this is absolutely contraindicated in hyperkalemia due to which of the following conditions? Well, out of the 5 options, it is absolutely contraindicated in hyperkalemia due to digoxin toxicity. We don't give. But why is it so? And that we will never understand unless you know the basic concept about what the mechanism of action of digoxin. Well, we are well aware that this increases the force of cardiac muscle contraction. That is so-called positive ionotropy, and that's why this drug is used in some cases of congestive heart failure. Now, it inhibits the enzyme sodium potassium ATPase, and this leads to increase in the intracellular sodium and extracellular potassium because this enzyme is not working. And now this sodium is exchanged with calcium. Sodium goes out and calcium comes in. And this increases intracellular calcium. And this increase in calcium increases cardiac contractility. Let me explain to you by this beautiful picture in front of you. So we have this sodium potassium ATPase, and normally this sodium goes out and potassium comes in. Okay, this is normal, what happened in the normal cardiac tissue. Now, when we give digoxin or digitalis, this inhibits enzyme sodium potassium ATPase. Now sodium will remain in the cell because it's not going out. So now this sodium will go out and this calcium will come in. It means, if I have to tell you, simplify the subject, initially sodium was dating with potassium. Now sodium is dating with calcium. When the calcium comes in, and dating was done by sodium calcium exchanger. I think day-to-day example you will understand better. Now calcium has come in and it bounds to contractile protein, and that leads to positive ionotropy. Point to be noted that when we are giving digoxin, potassium is staying outside and that induces hyperkalemia. This is the basic mechanism. Well, now the things are very clear, the cards are open. So as I told you, for any case of increased potassium in the body, hyperkalemia, we give intravenous calcium because it stabilizes cardiac membrane and it prevents arrhythmias. This is for any case of hyperkalemia. But in digoxin toxicity, if you give calcium, more and more calcium will come in and that will increase toxicity. That's why we never give intravenous calcium in hyperkalemia due to digoxin toxicity. So now there are 2 important points. Effect of digoxin on potassium and effect of potassium on digoxin. Both have effect, right? So let's learn both of them. So digoxin toxicity and potassium level, as I told you, that it is going to block the sodium potassium ATPase, and with the result, normally as I told you, sodium leaves cell and potassium enters, but blocking this mechanism, serum potassium will increase and that lead to hyperkalemia. So more and more calcium comes in, sodium goes out via sodium calcium exchanger. So intracellular calcium within the cardiac myocyte is increased by digoxin, resulting in increased cardiac contractility. Okay. Well, so we learned the basic mechanism why digoxin causes hyperkalemia. Now, as I told you, treatment of any case of hyperkalemia is by giving intravenous calcium. But in this condition, if you give it will go massive influx of calcium will happen. The point I told you in the previous slide also. But it will induce irreversible contractile state due to impaired diastolic relaxation from calcium troponin C binding. This is a binding protein, it's a contractile protein. It will keep on always contracting, so it will not relax, and this is known as stone heart. So stone heart is the heart, just like stone, the cardiac tissue is always contracting, no relaxation, so that can induce the state of stone heart. Now, I told you in the very beginning, what is the effect of hypokalemia on digoxin? Digoxin lead to hyperkalemia. Well, I have a question. Now, this is a question for you. Write down the answer. What is the effect of hypokalemia on digoxin? Digoxin toxicity actually get worsened with hypokalemia. Why? But digoxin normally bind to ATPase pump on the same side as potassium, as I told you. It's a sodium, potassium, ATPase, same side binding is there. So when the potassium level are low, then there is more and more place for digoxin to bind. So this how more digoxin binding will induce toxicity by hypokalemia. So end point of digoxin effect on to open membrane for calcium channel, and this results in increased calcium influx into cell, and this enhances digoxin toxicity. Now, one more question for you? Write down the answer. What is the treatment of digoxin toxicity? Of course, no need to say that we have to withhold the drug, digoxin, but what is the otherwise acute toxicity is there, how you are going to treat. Write down the answer in your copy. Well, treatment of digoxin toxicity, intravenous fluid are given for hypotension. Monitor potassium level is very, very important. Hypo and hyperkalemia both can create problem. Correct arrhythmias, and if hemodynamically compromised or serious arrhythmias are there, then you can go for digoxin specific antibody, so-called FAB, can be given. Now again, question for you, one more question, write down the answer. What is the indication of giving digoxin specific antibody, that is FAB? What is the indication of giving? Write down the answer in your copy. Well, we gave that FAB, DigiBand, administration include life-threatening arrhythmias that may include ventricular arrhythmias, ventricular fibrillation, tachycardia, asystole, complete or high-grade AV block, and symptomatic bradycardia. By and large, any dangerous type of arrhythmias, we have to give FAB, and or evidence of end organ dysfunction, renal failure, septic shock, liver failure, or altered mental status. In all these status, again, we give digoxin toxicity. Finally, if the potassium level is more than 5.5, then again, we can give this DigiBand. Now, if you look into other option, A and C are incorrect, acute renal failure and renal tubular acidosis. In this, we can give injection calcium gluconate, there is no problem. And B and D, amiloride and spironolactone, we know that they are all potassium sparing diuretic. They can cause hyperkalemia. So in this case, stop the drug is the best place. That will automatically potassium level come down. But still the potassium level is very high. You can very well give injection calcium gluconate. There is no harm. There is no contraindication. Okay. So golden line to remember, digoxin toxicity can cause hyperkalemia. Intravenous calcium is absolutely contraindicated in hyperkalemia due to digoxin. Digoxin toxicity is worsened by hypokalemia. So we have a 52-year-old male. He come to you because of chronic cough and recent bloody sputum. He used to smoke 2 packs of cigarettes daily for 22 years, but he quit last month. His other symptoms are weight loss, anorexia, constipation, increased thirst, and easy fatigability. Well, he thinks he's depressed because his wife died 4 months ago. His life never felt the same after that. On examination, slim man who appears to be pale, vital signs are stable, little irritable, and short of breath. Lab reports, they show hypercalcemia, and these are in the normal range. The higher mass in the left lung. Whole body scan shows no abnormality. Biopsy, the higher mass would likely to reveal what? Well, it's a beautiful question. The answer is squamous cell lung cancer of the lung. Most likely diagnosis of this cancer is squamous cell carcinoma of lung. Why? We know very well that in squamous cell lung cancer, hypercalcemia occurs. And this patient has many features which are symptom consistent with hypercalcemia are anorexia, constipation, increased thirst, and easy fatigability. But now I have a question for you. Write down the answer. Why increased thirst in these patients? Well, the answer to this question is because of hypercalcemia. These patients develop nephrogenic diabetes insipidus. This is the nephron, and normally the ADH act on the collecting tubule and it absorbs only pure water. Now, in these patients, because of hypercalcemia, this ADH is not able to act on the receptor. The water is not absorbed. Water goes out, and that leads to polyuria, and that leads to increased thirst. Thirst is secondary to polyuria. So this is secondary to polyuria. Well, I have got one more question for you. You write down the answer. The way hypercalcemia lead to this problem, tell me any other electrolyte imbalance which can lead to nephrogenic diabetes insipidus. Well, answer is hypokalemia also lead to nephrogenic diabetes insipidus. Well, it has been confirmed that lab report hypercalcemia is there, and squamous cell cancer mnemonic squamous. Okay, squamous is calcium. It's a beautiful mnemonic. Well, in addition to this higher mass on the chest X-ray, most likely lung cancer, which we are saying, squamous cell lung cancer. And remember, squamous cell lung cancer is a central mass. And the peripheral are adenocarcinoma. They are peripheral. In fact, small cell lung cancer, they are again central, but this is peripheral. Hypercalcemia usually is, now why hypercalcemia occurs in these patients? Because these tumor, they secrete PTH-like related protein or polypeptide. Point to be noted, it is PTH-like polypeptide, a molecule which has got exactly same function as PTH. Okay, same nature PTH, receptor binding. So they are going to bind to same receptor and that lead to hypercalcemia. Remember, in these cases, PTH level are usually reduced. So binding to PTH receptor by this PTH-RP, this increased calcium resorption from the bones, increased calcium resorption from DCT. These together, they lead to hypercalcemia. But now the question is, in this patient, whole body scan was also done. Write down the answer, why this scan was done in these cases. So why whole body scan was done? Hi, well, we have seen hypercalcemia. It may also result from metastatic involvement of bone, and which usually develop as a late complication of cancer. So it is very important to rule out secondaries in the bone for which PET scan was done. Now, a little bit more about basic concept of squamous cell cancer. Most common cancer in male smokers. Central location cavitation can occur, and it produces PTH-related peptide, which causes hypercalcemia, the point I mentioned to you. Little bit pathology, again, it is very important whether we are diagnosing in the management plan. This is must for every exam. Composed of polygonal cell with eosinophilic cytoplasm with distinct border. Well-differentiated squamous cell carcinoma show keratin pulse, cannot afford to, and there are intercellular bridges. There are two words you should never forget. Keratin pearl and intracellular bridges are one of the classical features of squamous cell cancer. And as per treatment plan is surgery. You can see keratin pulse, intercellular bridges you can see, lovely bridges you can see, and central location is there. You can see it's quite near the hilum. Okay. Well, you can see lovely bridges between the two intercellular bridges in squamous cell cancer. Very important in making a diagnosis. Now, what about tuberculosis? It's unlikely in United States or European countries. Unless patient has some kind of immunosuppression or patient is an immigrant. So this is ruled out. Small cell carcinoma of lung usually causes other paraneoplastic syndrome like ACTH production and SIADH, and this is due to this. It leads to Cushing syndrome. And due to SIADH, it leads to hyponatremia. Okay. Hypercalcemia is not a feature, rather in these patients hypocalcemia occurs in small cell. Why? Because these tumor also secrete calcitonin. Increased calcitonin lead to hypocalcemia. What about sarcoidosis? Is a very good important differential diagnosis. It also leads to hypercalcemia, but there are bilateral hilar adenopathy, erythema nodosum, they are absent, and chest X-ray, of course, in our patient, there is only left-sided hilar adenopathy is there, not bilateral, which is usually not a feature of sarcoidosis. But now again, one more question: why is hypercalcemia occur in sarcoidosis? This is the universal question. This is asked in all the exams throughout the world. Well, you can write down the answer. The answer is hypercalcemia and hypercalciuria occur in around 10% case of sarcoidosis. Mechanism is increased production of vitamin D by the granuloma itself. So it's more of an increased vitamin D, and that lead to increase. And why this happens? Because the increased alpha hydroxylase activity by the macrophages, and that lead to increased vitamin D synthesis. Okay. And this now vitamin D is level very high, that lead to increase intestinal reabsorption of calcium, and that lead to plus PTH are suppressed. The net result is increased calcium, increased phosphate, reduce PTH and normal ALP. Very cannot afford to this finding. Very important. Okay, just to inform you, in primary hyperparathyroid, which is due to adenoma, calcium high, phosphate is low, increase PTH, increase alkaline phosphatase. So there's a difference. You can see calcium, phosphate, PTH and ALP. What about adenocarcinoma of the lung? Is usually a peripheral lesion, not associated with hypercalcemia. And typically hypertrophic pulmonary osteoarthropathy? Well, again, a very universal question from immunology as well as pathophysiology as well as diagnostic. Which mutations are seen in adenocarcinoma? Well, KRAS mutation are seen primarily in adenocarcinoma, but P53, RB, and P16 mutation are an inactivation. A mutation and inactivation have same frequency in adeno as well as squamous cell cancer. It means this is the single most important mutation that must be investigated in case of adenocarcinoma. So golden line to remember, suspected squamous cell carcinoma of lung in a patient with a significant smoking history, hypercalcemia and high liver mass. Small cell lung cancer causes other paraneoplastic syndrome, ACTI production and SIADH, and this lead to Cushing syndrome, and this lead to hyponatremia. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine, there are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB medicine and family medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.